This is a general disclaimer. Redlands Community College attempts to have the most accurate and up-to-date information listed in its content and delivery. However, your education is your responsibility. Redlands Community College or Roy Smith makes no guarantee in the accuracy of this information in this video and accepts no liability for the informational video. The information expressed is strictly the opinion of the author and the presenter, which is listed in the reference near the end of the video. This information is designed to supplement your own education or initial education and should not be used to replace any current academic program you're enrolled in. View the information and content at your own risk. Thank you. This is going to be Chapter 8, Disorders of Oxygenation. And key concepts. Upon completion of this chapter, you'll understand that respiratory failure results from lungs' inability to diffuse oxygen into the blood, and this is going to be a specific type of respiratory failure, type 1 respiratory failure. That the environment, pulmonary, and cardiovascular causes for respiratory failure, we're going to learn that, and how treatment is aimed at improving diffusion while addressing the respiratory failure causes. Remember, this is the first type of respiratory failure. Chief concerns. Type 1 respiratory failure is caused from the lungs' inability to diffuse oxygen into the blood. Hypoxemia, partial oxygen pressure less than 60 millimeters of mercury. And this is table 8.1, so all of these would interfere with the diffusion of oxygen in the blood. Emphysema, and that would be from trapping of air. Pulmonary edema, and that would be from fluid in the alveolar sac. Pulmonary embolism, and this would be of a clog in the pulmonary artery. Acute asthma, and this would be because of bronchospasm. Inability to diffuse oxygen to the alveolar. And then pneumothorax, and this would be because of a dropped lung that caused pressure in there. You could not ventilate the alveolar space very well. This is table 8.1 in your book. Respiratory gases. Key concepts here. The concepts on this slide are what are the actual impacts of oxygen transfer. So when we look at gases that are in the body, we have kind of a benchmark, and the benchmark is does the hemoglobin molecule transport the oxygen gases or not? And we're going to talk about something called the oxygen hemoglobin dissociation curve, and there's several things that can adjust this. Just very simply, let's take a look at it here for a second. This is it at the bottom of the slide. Now, the blue is Johnny on the spot, so that means that at the cellular level, and that's what we're talking about down here, and this is a saturation at the cellular level, so we're looking at 90% here. Sorry about the crooked line. Now this isn't much of a curve here to this spot. We've already identified that anything under 60 is hypoxic, so that means if you get a sat below 90, let's say in the 80s, 80 is about right here. Does it make sense that they are definitely hypoxic? Because they only have 50 PO2 at the cellular level. Now, certain things in the body make this oxygen hemoglobin dissociation curve either shift to the right or shift to the left. And I'm going to kind of erase this here for a second. So, this is what we're fixing to talk about here down in this section. First, we're going to talk about Dalton's Law. I'm going to erase this and kind of explain. I like to look at Dalton's Law like Dalton's gang. What that means is that we only have so much of an air sample to begin with. And then each one of the gases that are in the atmosphere, divvy this up. Now, we know we have 21% oxygen in the normal atmosphere. Well, if this is a quarter, or 25%, give or take, this little wedge right here would be our oxygen. Now, the point of this is if we input another gas into this air sample, it will displace all the rest of the gases. So in Dalton's Law, the $5 verbiage is this: the sum of the partial pressures of each gas equals the total pressure of the gas mixture. So no matter what gas we add in here to this sample, we could add 15 gases, but it's going to displace what our normal air sample would be. Well, if they don't get enough oxygen to begin with, then that could definitely create hypoxia, very simply. So Dalton's Law is kind of important. the oxygen hemoglobin dissociation curve. We base this oxygen hemoglobin dissociation curve on the affinity for oxygen so the loving, so to speak, that oxygen and hemoglobin have for one another. Now, whenever we look at this, let's say that you have a decreased pH, which means you're acidic. And we'll talk about DPG here in just a second. Or an increased temperature. All of this is going to make our curve kind of shift to the left. Now, what that does is this red one here is that curve, that red dotted line that's on the slide. So that means that at 80% O2 sats, with any of this in play, decreases the amount of affinity that hemoglobin has for oxygen. So what that's going to do is that's going to make the cellular environment more hypoxic, which will send back more signaling to the brain. I'm hypoxic. Can you please compensate for this? Can you please help me with this? So this is kind of very important, understanding what makes it go right and what makes it go left. So affinity for oxygen, a left shift oxygen hemoglobin dissociation curve. The hemoglobin has a high affinity for oxygen, so it really loves it. It'll pick it up, binds to the oxygen more readily, and releases at the cellular environment more reluctantly because it likes the hemoglobin a whole lot more. Even this could be bad. A left shift. So we like to watch, we compare these very simply from ABGs, arterial blood gases, when they get to the ER, versus what we get on the pulse oximetry and what's going on in the environment. One of the things that you always have to do for ABGs is identify what the pressure is in the air. That zeroes out or gives the arterial blood gas something to look at. And what the arterial blood gas is showing you are the partial pressures of that gas in that sample. So when we get a PaO2, this is what we're referring to. How much oxygen is at the cellular level for the cellular environment. Now, the Bohr effect, what that does for us. The Bohr effect adjusts this oxygen hemoglobin dissociation curve because a decreased pH also means that you have a high acid level. And the one that we see normally occur in this is CO2. So high amounts of CO2, we got loads of building blocks, so we can make carbonic acid quite readily. And just to talk about that for a minute, bicarbonate pretty much picks up an extra hydrogen molecule, which makes it, this is carbonic acid. And this is bicarb. Now, our red blood cells have a device on them called carbonic anhydrase, which and it adjusts the buffering system off of CO2, and will readily, easily make this right here, this guy, carbonic acid, a reversible reaction. And I'll show you what the reversible action is here in just a second. So it'll easily break it down into water and CO2 once it's picked this up. Now, this is a red blood cell that does this. Also, the red blood cell holds hemoglobin and carries the oxygen. So it's the guy down in the ditch. It's the guy that's doing looking at minute-to-minute, second-to-second acid-base reactions and figuring out if I need to liberate carbonic acid and make CO2 and water to reduce the amount of acid, or put it together because I haven't got enough acid. So it's doing this minute-to-minute, second-to-second. Now, this goes to the kidneys if we have kidney function and gets expelled as urine. And this, if the patient hyperventilates themselves a little bit, breathes off as CO2 in our returning sample. Now, what that does for us is that eliminates an acid. So in the overall scheme of things, the body can quite readily either eliminate the acid or carbonic acid and then put carbonic acid together if it needs to. So if you're alkalotic, it can put together carbonic, it has readily available has CO2 and water that it can form through the red blood cell and make carbonic acid. So it's kind of an easy way and a rapid way of adjusting acid-base derangement. Okay, so things affect this. The Bohr effect, if you're acidic, what the Bohr effect does is it right shifts it because it has a reduction of pH. And the Bohr effect immediately offloads the oxygen off of the red blood cell when it comes in contact with acidic environment, because it's thinking and it's used to seeing high amounts of CO2, and then the body's going through there and turning it into carbonic acid. So very simply, if your patient is acidic, we may not be getting oxygen to the tissues to begin with, because as soon as it sees the acidic environment, if this is systemic, it's going to offload. We're going to talk about carbon monoxide. Carbon monoxide is a thorn because it has a greater affinity due to its nature than oxygen does for the hemoglobin molecule. So what that means is that it has a 200 to 250 times greater affinity for hemoglobin than oxygen. So it's going to stick to it, and it doesn't want to get off. So whenever it's passing around the cellular environment, it just stays on there. So your sampling goes down when you're looking at end-tidal CO2. The SATs are going down. The SATs are extremely high because it thinks that the red blood cells is completely loaded. The pulse oximeter can't tell the difference between carbon monoxide and oxygen. However, if we did an ABG on this person, the PO2 levels will be dropping. Methemoglobin anemia or methemoglobin. Whenever we see methemoglobin, this causes a shift to the left. It's an adjusting or a change of the hemoglobin molecule itself. It's great for cyanide poisoning because it will readily pick up cyanide and eliminate it a little bit faster and reduce your overall cyanide levels. And we use things like sodium nitrate, sodium thiosulfate, amyl nitrate to create methemoglobin or methemoglobin in the system. And what that does for us is it helps eliminate cyanide, because that's a cyanide antidote kit. But in the normal person, if they're on nitrates or certain medications, it may increase their amount of methemoglobin. Now, PaO2 is important because it's the amount of oxygen that's available to the cellular environment. The total oxygen content is essentially a math formula. The math formula is kind of like this, that the total oxygen content, the amount of oxygen carried in the hemoglobin, and the amount of oxygen dissolved in the blood. So, if we're looking at total oxygen content, we're looking at how much oxygen is actually getting to the cellular environment and how much is carried by the hemoglobin molecule. Because of its affinity, what we might see here is the greater affinity it has for it, it won't want to release the oxygen. The less affinity it has for it, it never picked it up to begin with. So this is what this left shift, right shift, oxygen hemoglobin dissociation curve kind of shows us. Now, DPG, let's talk about it. We kind of skipped it. DPG, we find, and we're still studying it. So we find that people with certain specific chronic illnesses have a higher amount of DPG. It is likely created by the red blood cell as an adaptive measure. Hypoxia, CHF, chronic lung disease, we all see high levels of DPG in these people. And rightly so, pH decreases, CO2 comes up, carbonic acid is more readily available, changes their acid-base derangement. So an increased concentration of DPG favors formation of low affinity states of hemoglobin. So by doing this, by making DPG, the hemoglobin itself does not have as great of affinity for oxygen as it should. So whenever we're looking at this, an increased amount of DPG will shift this oxygen hemoglobin dissociation curve to the right, and thereby reducing pH. It's kind of a self-perpetuating circle here. And this is all about the cell's interaction with gases. Oxygen hemoglobin curve, back on this, the affinity of oxygen for hemoglobin and the tendency for it to release can be affected by temperature, acid, as well as partial pressure of oxygen in the alveoli. The Bohr effect, the more acidity that someone has, the greater chance that they have to have a right shift. Differential diagnosis. Understanding type 1 respiratory failure. So kind of take an outside to an inside approach. Please remember that it starts with oxygen in the atmosphere, moves into the passageways of the lungs, the oxygen does, and continues to diffusion of oxygen at the alveolar capillary interface. This loads it onto the hemoglobin molecule and gets it to the tissues. Causes of low inspired gas. Gas density determines whether it's lighter or heavier than air. So if you, it's just like Dalton's gang, if you impose another gas that is in the sample and it displaces the rest of the gases, you're getting less oxygen. High altitudes reduce oxygen availability for diffusion in the lungs. The percentage is still the same up there, but the pressure is different. Type 1 respiratory failure causes includes barriers to the pulmonary tree, extrapulmonary causes. An example of this would be opiate overdose. It would stop your respiratory drive. And impairment of the alveolar capillary interface. Pulmonary embolism, etologies mnemonic, is FACCT, fact, fat embolus, air embolus, childbirth. We can get an amniotic embolus, cancers, and thrombus. Key concepts. Thrombus is the most common source of a PE, and the most common source of this is a venous thromboembolus. Vicrose triad, venous stasis or stagnant blood, a state of hypercoagulability, and an inflammatory injury of the endothelial wall inside the vein. Now, all three of those together, that's called Vicrose triad. That will generally form a deep vein thrombosis, which is essentially a PE waiting to happen. A DVT can form in any of the deep veins of the legs, femoral or popliteal or pelvic veins. A Hohmann sign, and this helps us kind of identify if we might have a DVT, is pain at the back of the knee with dorsiflexion. So we bring the foot up on the affected side and you'll have pain in the back of the knee. Pulmonary embolism, symptom complex, all of a sudden unexplained difficulty breathing or dyspnea, pleuritic type chest pain, and then you may have hemoptysis with it or bloody sputum. 12-lead EKG, pulmonary embolism, may show signs of a right heart strain. That would be a new onset right bundle branch block, the three rights, right ventricular hypertrophy, right bundle branch block, and right atrial enlargement. May also show signs and symptoms of acute cor pulmonale, large S wave in lead 1, a Q wave in lead 3, and an inverted T wave in lead 3. SQT, an S1, Q3, T3 is what that's called. Or the most common sign and symptom is a VQ mismatch. Ventilation to perfusion. You go there, they're short of breath, they're starved for air. You listen to their lung sounds, and their lung sounds are clear, but yet their SATs are like 70%. This comes to mind in this as well. Failure of the alveolar to expand naturally during inhalation. The treatment of a PE, aggressive treatment while en route to the hospital, high flow oxygen and high concentrations, administration of fibrinolytics at the hospital. A saddle embolus is something that takes out a very large content, though. This would be a massive PE. A large embolus that straddles the bifurcation of the pulmonary artery, so this will include a good large percentage. It may not be survivable. Pneumonia, microorganism cause infection. Key concepts on the etiology. Common thread is the presence of an infectious microbe. Microbes are categorized as fungal, bacterial, or viral. Viruses are also capable of causing pneumonia. Examples of this are going to be SARS, or severe acute respiratory syndrome, transmitted from one person to another. Cause of this is a coronavirus. Walking pneumonia, primarily atypical pneumonia. It's a pneumonia that is not so debilitating as to require bed rest, although it is incapacitating, has a protracted recovery, and is often resistant to antibiotic therapy. Bacterial pneumonia, causes of bacteria in the environment. Pneumococcal pneumonia and streptococcal pneumonia come to mind on this. We get all kinds of nasty pneumonias now because people don't actually take all of their antibiotics. So we get drug-resistant streptococcal pneumonias. Indiscriminate prescription of penicillins in non-compliant patients have led to the emergence of methicillin-resistant Staph aureus, or MRSA, and drug-resistant streptococcus pneumonia, or DRSP. The pneumonia vaccine has decreased the overall number of cases of strep pneumoniae and lowered that of the drug-resistant strep pneumoniae as well. Penicillin therapy, many patients are allergic to it. Whenever a patient is on any antibiotic penicillin, allergies should be highlighted in the patient's record, and be sure you're not giving them something that they're allergic to. We don't want to cause anaphylaxis on top of hypoxia. History of type 1 respiratory failure focuses on ascertaining the symptom complex. Paramedics can compare it to symptom patterns of common causes and ascertain the diagnosis. Classic symptom complex of pneumonia is fever, cough, shortness of breath, and chest pain. Fever compounds the problems of hypoxia. May result from pyrogens, fever-producing substances, releases within the body, endotoxin, remnants of the bacteria, activate the inflammatory response system. Shaking and chills are often associated with this as well. Fever goes up, we get a higher temperature, we get a right shift of the oxygen-hemoglobin dissociation curve. Productive cough, effort at clearing the airway of secretions, purulent sputum, drainage of pneumonia. Now this would be pus essentially in the sputum, so very thick, viscous looking, smelly upon smelling it. Consolidation, we might get consolidation of a pocket or two of this, and this would be a pocket of pus. Non-productive cough can also be pneumonia, also suggestive of many other disorders. Additional symptoms, night sweats, and unexplained weight loss. Medical history is going to be essential. If the patient has an aspiration risk, present strokes, acute alcohol intoxication, esophageal disorders, gastric esophageal reflux disease, weakened lungs or immune system, pneumonia can flourish. Inability to raise the sputum, anybody that has this is at a greater risk. Neuromuscular diseases as well, the patients will be at a greater risk from inability to bring up the sputum. Opiate use can help decrease patient anxiety and encourage deep breathing while also depressing respirations. So be aware of that. It's a kind of give and take. Ample allergies medication, past medical problems, last oral intake, and anything that I should be aware of events leading or preceding the incident should be obtained. Examination considerations, primary assessment, address any immediate threats of the ABCs in that, obtain a medical history, see what their chief concerns are, assessment, if they have inadequate breath sounds or advantageous breath sounds or rails, please make note. Find the clinical indications. Table 8.6, clinical indicators of pneumonia. Temperature greater than 38 degrees Celsius, which is about 100.4. Tachycardia, rails and crackles, diminished breath sounds, productive cough, shaking and chills. Pulse oximeter is the most non-invasive way of doing this. The pulse ox is a non-invasive probe. 2 light-emitting diodes, or LEDs, pass red infrared light through a capillary bed to a photodiode, frequently placed on earlobes or fingertips. Oxygenated blood absorbs more infrared light. Pulse oximetry compares the difference, and it gives us a percentage of oxygenation at the cellular level, or at the capillary level. Cyanosis, bluish discoloration of the skin. It's an indicator of hypoxia. We should probably not let them look like a Smurf or get completely blue before we actually start aggressive treatment on a respiratory case. Types, peripheral cyanosis can be due to hypoxia or can result from poor circulation in hands or feet. Central cyanosis is more likely due to hypoxia, and that would be at the core. Cyanosis is not a dependent sign of hypoxia. Assessment. Unresolved hypoxia. Following administration of high-flow oxygen, diagnosis of type 1 respiratory failure, the treatment is pretty much supportive care and rapid transport. Treatment considerations. Normal oxygen delivery, approximately 1,000 liters per minute, or VO2 max oxygen consumption. Cardiac output and oxygen demand. We should consider the Fick equation. Very simply, the Fick equation is the amount of oxygen delivered to the tissues, or the VO2, equals cardiac output times the arterial oxygen content minus the venous oxygen content. So what we'll see there is we'll see the difference between those two, what's in the arteries, what's in the veins, and then what was available at the cellular environment. Patient positioning, seated in an upright position, especially if they have fluid. They're going to feel like they're drowning if you lie them down. Acute respiratory distress syndrome, acute lung failure, often associated with pneumonia. Key concepts on this, this is non-cardiac pulmonary edema. The difference between type 1 respiratory failure and ARDS is in ARDS, we have an increased permeability of the alveolar, and this is what gives us a result in acute pulmonary edema. Treatment includes aeration, continuous positive airway pressure, intubation, low volume ventilation, and positive end expiratory pressure. And essentially what we have in ARDS is in adult respiratory distress syndrome or acute respiratory distress syndrome, the alveolar sac that is supposed to be in contact through a basement membrane with the capillary has released itself for whatever reason. Pneumonia is a really good cause of this, and we see it often in pneumonia. But whenever that occurs, that allows for fluid to spill into the alveolar sac that was once not there. So our target goal here is to keep those alveolars open, and hopefully they will re-adhere where they're supposed to. The goal of respiratory therapy, maintain adequate oxygenation with a pulse oximetry or an SaO2 greater than 85%, but we would prefer greater than 90. Disposition. Mortality rates for ARDS average is about 40%. Advanced with age, about 70%. Rapid transport to a capable facility, and it's very critical in the treatment. We have to try to oxygenate them by any means necessary. Conclusion. Many disorders of impaired oxygen and produce hypoxemia. Paramedics must aggressively intervene in the patients with impending respiratory failure. Attempt to improve oxygenation at all costs. References for this chapter were taken from Professional Paramedic Volume 2, Medical Emergencies, Maternal Health and Pediatrics of Del Mar Learning. And if you have any questions, feel free to contact me. My name is Roy Smith, roy.smith@redlandcc.edu. Thank you.